Assalamu alaikum wa rahmatullah. Good morning, everyone. And thank you, Professor Nasser, for the kind introduction. So, excuse my voice because of my sinusitis. So I was asked to present to you today the recent trials on vitamin D. Many of you are probably aware that there has been a lot of debate over whether vitamin D is the good or the bad, particularly in bone health, but also the extra skeletal benefit. So I have no disclosure related to this presentation. So many of you probably remember that was our dilemma 10 years ago, whether calcium is good or bad. And I hope that we are probably over that. The new debate is on vitamin D. So around 15 years ago, roughly around 15 years ago, Prof. Nasser probably remember that very well, that many of us in the field of vitamin D were very thrilled about all the articles and publications coming on vitamin D influence, not just on the bone health, but the extraskeletal benefits. There were so many publications coming telling us that probably vitamin D is good for every disease under the sun. And many of you who were here around 10 years ago remember the H1N1. There were so many publications claiming that it's good for H1N1. So H1N1 was very similar to the COVID-19 epidemic that we lived through the last 3 years. And there were, as I mentioned, too many publications. We were not keeping up with the data being generated. And if you Google vitamin D on PubMed, you will see that probably the explosion came around 2009, 2010. Whether you Google vitamin D alone or vitamin D supplement, you can appreciate the number of publications that came through. So those were exciting years. And there were so many, hundreds of publications proving to us that vitamin D, through the action on vitamin D receptors, is probably acting on every organ and every tissue in the human organism. They were mainly observational trials, large cohorts, epidemiological data, very few randomized clinical trials, but the evidence was overwhelming, and those were exciting days, as I mentioned. So the IOM, the Institute of Medicine, around 2010, decided to put a brake on our enthusiasm. So they had this report. By the way, the IOM now, they've changed their name. It's called the National Academy of Medicine, if you Google them. So they mentioned that maybe the DRI, the daily requirement intake for vitamin D should be around 400 to 800. And this is sufficient enough to make 97, now I'm not sure if I'm using it seems, oh, there's no laser pointer, okay. Okay, so I will just, advance it. Yeah, so they mentioned that a sufficient level, or 50 nanomole, in 97.5% of the population is good enough for bone health. And that's what we should aim for. And any higher level than that probably is not advisable. As a matter of fact, they mentioned if we go above 125 nanomole per liter, which is around 50 nanogram per deciliter, if you're familiar with this unit, it's probably not safe. And they also went ahead to mention that what we have been hearing about the involvement of vitamin D in cancer prevention and so many other chronic diseases, diabetes, infection, autoimmune, other extraskeletal, we do not have data for that. So it's inconsistent, it's inconclusive. Maybe there is a U-shaped effect, so too little is bad, but too much is worse. And we should not be advocating a higher vitamin D doses or higher vitamin D levels for these diseases. But they went ahead and said, we probably need large randomized controlled trials. So they did support the idea that we need large randomized controlled trials. And I just want you to pay attention to the last two sentences, because we're going to come back to that. More than 10 years ago, they mentioned that maybe we should also consider the variables. So it's not just the dosing of vitamin D. We should be looking into adiposity, body composition, race, ethnicity, genetic factors, and so many other associated factors. So that was there. And then came the large mega trials. So we call them mega because they involved a large number of cohorts. If you go to something called clinicaltrials.gov, you will see probably at least 100 trials, randomized trials going on with vitamin D. Some of them were published, some of them are still going on. We are not going to have the time to go over all of them. We're going to focus mainly on the first 3 or 4, which is the VITAL, the one in America, the VIDA in New Zealand, the Do Health in Europe. Maybe we'll touch on the prevention of vitamin D in the United States. I'm just going to highlight 2 things over here before we move on. Look at the baseline vitamin D, because this is very important. We're going to go over this again and again. So the cohorts largely were vitamin D replete population. They were not deficient. And also look on the right side of the table, you will see that they were using much higher doses than recommended by the IOM. So they were using 2,000 a day, sometimes 4,000 a day in the vitamin D with diabetes. And in the New Zealandan one, they were using 100,000 a month. That's more than 3,000 a day. So they were using huge doses. And again, as I mentioned, we will focus on maybe 3 of them. The largest so far is the VITAL, that's the omega-3 and vitamin D. They recruited more than 25,000, and it's the longest run. It went on for 5 years, 44 centers in the United States. Mainly the major primary outcome was prevention of cancer and cardiovascular diseases. The VIDA, which is in New Zealand, were mainly again addressing cardiovascular events and mortality, among others. All of them had secondary endpoints we will discuss later on. The Do Health was also important in Europe, addressing multiple primary health outcomes. So this is the main 3 we will be addressing: the VITAL in the States, the VIDA in New Zealand, and the Do Health in Europe. They were mainly published in 2019 and 2020. So these were the major trials of recent publication. Let's start with the bad news. So the bad news is that the conclusion of these primary endpoints that vitamin D doesn't work. But before you get despondent and leave the hall, I want you to bear with me as we dissect some of these trials. So that was the initial conclusion from the primary endpoint. But again, they emphasized the primary trials as well as the review articles. They emphasized that there is no debate over the importance of vitamin D in the prevention of vitamin D deficiency. So they did not challenge that concept. The challenge was in the other effects. So there have been multiple review articles coming between 2020 and 2022. Many of them are really excellent. This is one of the best one, the most recent one of them in 2022 by Roger Boyon on the health effects of vitamin D. I'm going to be quoting some of what he mentioned. So these are the trials again. If you want to go quickly over them, the VITAL was the omega-3 and vitamin D for cancer and cardiovascular. The largest trial so far for 5 years. The VIDA was in New Zealand. Again, it was assessing cardiovascular, cancer, and mortality. And the Do Health I mentioned to you in Europe. And we will be touching on the vitamin D very quickly. And this is more or less the same conclusion. So in a vitamin D replete population, those trials with high doses did not show any benefit. So that was the conclusion of many of the review articles. And just quickly, I will just present 1 or 2 slides for you if you are interested to go and read them. So this is the VITAL, the one that was published in 2019 in the New England Journal of Medicine by Joanne Manson and her group. And I'm going to be highlighting 1 or 2 important parts here. This is the vitamin D intake in the population. They allowed vitamin D in the placebo group up to 100 units. So 40% of the placebo group or the control group and 40% of the treatment group were already on vitamin D. And a smaller percentage, around 4-6%, were on a higher doses than 800. And the baseline, as you can see, the mean was 77 nanomole. Only 12% of the cohort actually classified as vitamin D deficient population. And we're going to come to that again as a confounder in those trials. The second one was the VIDA trial, and that was in New Zealand. And again, the main aim was to prove they used 100,000 international units a month, which is a huge dose, and it was monthly, not daily. And even though the exclusion criteria mentioned that patients should not be on vitamin D, 10% of them actually, around 8 to 10% of them were actually taking vitamin D. Again, the mean baseline was around 60, which is normal, and around 30% had a deficiency. The Do Health is a very ambitious trial that was done in 6 countries in Europe, and you can see many famous names over there. And mainly they initially wanted to study 6 major health outcomes, including blood pressure, cognitive function, non-vertebral fracture, and infection, but there were secondary endpoints. One of them I'm just going to mention quickly, but before we do that, again, 10% of the population were, 10% of the cohort were taking vitamin D. The majority, around maybe 60% or so, were normal, and around 40% were deficient. Now, this is a secondary end analysis of cancer. And the reason I'm mentioning it here because I'm going to go over the secondary analysis or the subgroup analysis that came later of all the major trials. So in the cancer endpoint, they proved that actually vitamin D alone, omega-3 alone, a simple muscle strengthening exercise alone, all of them are effective in reducing cancer. And if you combine them, that's even better. So in those vitamin D replete cohort, when you give a high dose of vitamin D, which is 2,000 a day in that study, actually they proved that they can reduce cancer. Of course, that didn't stop people on the other side of the vitamin D debate. Many of you are familiar with the renowned Boland. So Boland, even before the major trial's conclusion in 2018, he mentioned that this was a research waste. Because how are we going to study vitamin D replete people to say that vitamin D is good for prevention of certain diseases? And he might be partially right in that, because as I mentioned to you, most of them were replete. Other researchers, like the famous Stefan Pilz in his review, said we should not be that critical. They did a good job, but they again proved that if you have a vitamin D replete population, maybe you will not see the results you are aiming for. This is an Italian group that published in 2019 their critique of the VITAL study. And this is like a summary of the confounders they talked about. And you can see on the left side, they mainly addressed that we didn't have vitamin D baseline level for at least 40% of the population. We don't have a follow-up vitamin D level for the whole cohort. We only have it for 6%, as I will mention to you later. We did not control for exposure of vitamin D in the control group. So we did not stop them from taking vitamin D therapy. We did not control for sun exposure or other confounders. So maybe we don't have the right to say that these trials were obsolete just because they didn't address this issue. And they actually mentioned that Jo Manson herself, in the first trial of the VITAL, said that this is a major confounder, that they allowed vitamin D in the control group. And they mention also the critique, the self-critique of the VITAL study research group, that, for example, in cancer, when they excluded the first two years, allowing for this cancer latency phenomena, actually there was a 25% reduction in the mortality of cancer. And they correlated some of the results to the BMI. So they found that those with a normal BMI, those with less than 25 BMI, actually had lower risk of cancer. So there were cracks coming now in these results of those mega trials. There were confounders, and we started to see more and more reanalysis and subgroup analysis coming from the same group. And this is the same group of the VITAL trial, mentioning that maybe there is an ethnicity factor over here. There is a trend for lower cancer in the African American. And also for the advanced metastatic cancer, which wasn't there at baseline, there was a reduction in advanced metastatic cancer in those who were repleted with vitamin D. And again, in the same study I mentioned by the Italian group, they mentioned maybe we should look at the other confounders. What is the baseline vitamin D? What are the confounders in the population? The body fat percentage, the genetics, the other medications, and the seasonal variation. You remember Boland. So we had a group from America, and these are very famous names in the bone field. Stephen Cummings and Clifford Rosen. You will see their names in many of the publications on vitamin D. Again, they were very harshly critical of the VITAL study conclusion, and they actually mentioned that since we could not prove that they even can prevent fall and fracture, why are we doing vitamin D testing, and why are we supplementing vitamin D? And they cautioned against doing that to prevent major diseases or to extend life. So they were as harsh as Boland in their criticism. But this is another group. This is a group that started having meetings in 2017 just to address these controversies in vitamin D. We've been debating this vitamin D for over 20 years now. And that group have been convening in Italy mainly, but they are European researchers, American. One of them is from New Zealand and one from Brazil. And again, they just reiterated the same thing. The large trials had a normal vitamin D population. So all of them, the majority were normal, and you can see the percentages of the population who were vitamin D deficient. So the conclusion is that when you give vitamin D to already replete population, you probably don't see a lot of result. But don't forget the subgroup analysis we talked about, because we're going to come to that. The same group, the vitamin D controversy group, they mentioned another publication a year later, and they introduced this interesting concept that maybe we should not have a standard approach to vitamin D. So one single dose for every disease doesn't work. Maybe we should have different doses and different levels of vitamin D for different organs and different diseases. And this is not a very new concept, by the way, as I will come to later on. So the conundrum we are in now, how do we reconcile what we know of the trials and what's happening in reality? In reality, we know that vitamin D deficiency is endemic in many places, in many regions in the world, including our area, the Middle East, the North Africa, and North European countries. So how do we reconcile this? And how come a nutrient like vitamin D, with a very rich history spanning more than 350 years, 2022 was the 100th anniversary of vitamin D discovery. So how come we're still debating whether vitamin D is good or bad? So for the sake of time, I'm just going to skip through a few slides that tell us about vitamin D metabolites being an active hormone, and it acts as a hormone on vitamin D receptor, and how we progress from a simple pathway of understanding how vitamin D comes from the sun, gets hydroxylated in the liver and the kidney, and mainly acts on the bone, to understanding the intracellular pathway and the presence of the 1-alpha hydroxylase in many of the cells, the vitamin D receptor signaling, and how that correlates with so many diseases. I'm just going to go over one or two important slides. There have been very elegant studies over the last few years on how the genomic and non-genomic and the epigenetic function of the vitamin D acts intracellularly. And that made us wonder, how come we don't see the results that we already know about? Okay, so this is really confusing. It was very confusing for me as well. How can we figure out, I mean, we talked about the confounders, but how come we can't find trials proving that this beautiful molecule we call vitamin D, but it's a hormone, exert this action? And I couldn't find anyone better than the late Robert Heaney. Many of you probably know about Robert Heaney. He is a legend, not just in osteoporosis field, but in calcium, vitamin D, and PTH. He's been publishing since the 60s on the relationship of calcium, vitamin D, and PTH. What Heaney said is, we are studying vitamin D wrongly. Vitamin D is not a drug, it's a nutrient. It does not follow a linear pathway like all medications do. It has an S-shaped phenomena. So too little is bad, but once you have reached the maximum level, which we can argue over, you don't see any benefit. And maybe this explains why we didn't have the effects we wanted to show in the major trials. And this have been adopted by many authors. So the randomized controlled trials studied vitamin D as a drug, and they did not make sure that the control group were not exposed to vitamin D. Biologically speaking, you cannot prevent vitamin D exposure in a control group, because either they will be exposed to it through the skin and the sun, or they will take it as they were allowed in the randomized control trial, or there will be confounding factors, as we talked about. Actually, he proposed guidelines for optimizing design and analysis of clinical study of nutrient effects. And just for the sake of time, I will not go over all of them, but he emphasized that vitamin D level as a nutrient should be included in the inclusion of the trial. We should have the baseline value for vitamin D at the start and at the end, and that we should allow for the confounders to be studied as well. Other nutrients, exposure in a non-supplemental way, like sun exposure, among so many others. By the way, that was published in 2015. Robert Heaney died in 2016 at the age of 88. So he was very active till the end. And these are the other nutrients he was talking about. So vitamin D doesn't work alone. That's another thing with vitamin D being a nutrient. It's not a drug. So it doesn't work alone. It needs vitamins and minerals and fat in the meal for proper absorption. And this was, again, emphasized by many other researchers later in the field. as well as talking about the genetic polymorphism due to the VTR signaling. I'm just going to touch quickly on the relationship of weight. As I mentioned, remember we talked about those with normal BMI having a better response to the vitamin D. And this again was emphasized in this beautiful study in 2014 from a Canadian group. And you can see for the same dose of vitamin D, the level of 25 vitamin D will change. So the obese or the overweight will have less of the vitamin D level with the same dose you give. And that's a major confounding factor in many of the trials. And the same vital group researchers went on to publish reanalysis of their data, and they mentioned actually BMI was a major confounder, so that the biomarkers of vitamin D were blunted in the obese patients who were given the same dose of vitamin D. So that was an interesting outcome. Now, the renowned William Grant from the USA also proposed in a recent review article, remember what I mentioned about different levels for different organs and different outcomes? He proposed the same thing. So he reviewed multiple publications, whether they were observational, randomized controlled trials, or epidemiological data. And he mentioned that maybe different levels act differently in different organs. And this was also actually adopted by many societies, including the Grassroots Health Society. And they mentioned that this 50 nanomole, which was proposed by the IOM, maybe it's good for vitamin D deficiency, for preventing rickets and osteomalacia, but it's not good enough for other diseases we are studying. We probably should aim higher than the 50 nanomole. And again, maybe something like insulin resistance in the diabetic population should be addressed with a higher than 50 nanomole, maybe 80 nanomole or even higher. So this optimal level is probably optimal for one organ or one tissue, but not optimal for all the other. And this was actually shown beautifully in the vitamin D to prevent type 2 diabetes. So the initial study, the first trial, even though they were using 4,000 international units, which is a humongous dose, for 3 years, by the way, showed there was no difference in the two groups. When they did a reanalysis, a post hoc analysis, they found that those who were vitamin D deficient actually were less likely to develop diabetes when they were repleted, but also if you maintain a higher vitamin D level, much higher than what all the societies are talking about, somewhere between 100 and 125 nanomole, which is around 40-50 nanogram, there is a massive reduction in the conversion of pre-diabetics to type 2 diabetes. We're talking about a magnitude of 50-70%. This is a big deal. And they went on to say maybe we should study that further. So just for the sake of time, I'm going to skip over this new concept of the Mendelian randomization study. This is a genetic study that correlates the genetic variants of vitamin D deficiencies to the outcome. So I will skip over these two. And the last two slides, it's more or less what I've mentioned early on. Many of the eminent researchers, like Barbara Bosher from the UK, mentioned the same confounding factors, that we didn't have vitamin D for the whole cohort, that the majority were vitamin D replete, that we did not correct for the confounders. And again, this is a beautiful review in 2022 mentioning the same thing and addressing this optimal level we just talked about. So I'm going to conclude by what did I learn from my review of those articles. And these are just simple, basic ones. Vitamin D is an interesting molecule. So it's a nutrient that acts like a hormone. We understand how it works in the intracellular genetic machinery. We've come a long way in our understanding of that enigmatic molecule. We do know that it's not a panacea for all diseases. It can't work alone. There are so many other cofactors that work with vitamin D. It doesn't make it less beneficial. So we really have to keep an eye on the other confounders, that this optimal level we've been talking about is not like one level for all diseases, one level for all organs. I think my simple approach would be you always have to correct the deficiency. You always should try to maintain an adequacy all the way from childhood to very advanced age. Maybe we should be targeting the upper safe levels and not the low safe levels. And the only way to do that safely is to do periodic testing of vitamin D. And we do understand that the kits for vitamin D assays are expensive, but you don't have to do it every month or every 2-3 months. Maybe twice a year should be important. So this seasonal variation in vitamin D is important. We should pay attention to confounding factors. And please do not throw the baby with the bathwater. So we're going to be hearing a lot about these trials again and again. There is a new guidelines coming from the Endocrine Society in 2024. So with that, I thank you for your attention. Thank you very much.